Thank you. So who's been to the JFK library before? Hands? Before? Yeah? Who was able to find it this morning on their GPS? Right? Didn't show up. Columbia Point. So I am the president of New England Hymns, and actually this is the latter half of my year. And I was just commenting with one of the former presidents. It's been a great year. We have 2,800 members. That's the largest chapter in Hymns. So we're having a regional event today, and what we try to do is we try to have topics that make sense to the region. And I think kicking off the morning talking about epic implementations, whether you're down in Rhode Island, Connecticut, Maine, that makes sense, right? Ending the day talking about ICD-10 in business informatics, pulling that information in, that makes sense, right? I mean, that's where your clients are. That's where your physicians are, your providers are. So we're excited. We, as you can see behind me, we have a good lineup. Actually, if you look past me and behind the screen, we have a good view. So I'll actually say a few more things about the venue. So we wanted to have a venue that, kind of like I talk about here, we have topics that make sense for the region. We have a location that makes sense for the region too. This is our first time doing it at the JFK Library, and it's a view of Boston. And it's just, I think it rained all week. I don't know, I travel a bunch, but the sun came out for it. If you haven't been, it looks like probably about 50% of you have not been to the JFK Library before. You have free admission, so go after the presentations, walk around. I think they have the Cuban Missile Crisis, so some pretty interesting stuff. But yeah, as far as the presentations today, we have a good lineup of speakers. We tried to go regional. We start at Boston Medical, and then we jump over to Yale with an epic implementation. And as I said, we end the day with business informatics. Hymns itself, in New England Hymns, it's a volunteer organization. These are all positive things about the region pulling this together, but everyone who pulled this together is a volunteer. So if you get a chance, we have badges and it says board member. Ask us about the organization. Ask us how you can help, or just wow, how'd you pull this together? Or when's your next event? Or we have a transition coming up to Ralph Johnson, the upcoming president. So talk to him. Be like, hey, I have this great idea for next year. You could have an event around this, or really enjoyed the format today, but maybe you could do this, this, and this. So we're here to hear that information. But then we couldn't have had this event in addition without the sponsors. And so we're really fortunate. We have a good base of sponsors who will, some of them coming up here doing introductions, but regardless, they all have some giveaways this morning. You should have picked up a form and fill that out, talk to the different sponsors. Again, they contribute to this event. They're one of the reasons why it happens. They're regional. And as far as the form goes, make sure you sign it on the top, because there will be a raffle, and we need your name on that. So, but then outside of that, again, thank the sponsors, and I don't know, just excited. So thanks for coming. The format, we'll roll over to Eric in a second here with BMC, and then we will wrap up the day around 3 o'clock. So thanks for coming. And now Jessica Doherty will do the introduction. So Eric, if you're ready.
Hi, I'm Jess Doherty. I'm the programs chair for New England Hymns this year, and I'm with Queen Associates, which is one of the sponsors for the chapter. And I'd like to introduce Eric Quadratic to you today, our first speaker. Eric Quadratic is the Director of Electronic Health Records at Boston Medical Center. He has over 16 years of experience working in the healthcare industry in both technology and clinical roles. Eric has spent the majority of his career overseeing the implementation and ongoing support of electronic medical records in a variety of settings. In his current role at Boston Medical Center, Eric is the program director overseeing the eMERGE project, an initiative to replace the existing fragmented EMR with an integrated solution. Eric holds a bachelor's degree from the University of Connecticut and an MBA from Bentley University. Please welcome Eric Quadratic.
Thanks, Tris. Good morning. So when Linda called and asked me to do this, I said, sure. And then I hung up the phone and I said, I hate public speaking. Why did I agree to do this? So, as I get started, one of my friends at work had told me, public speaking, one of the things to do to get started, set the mood right, show your kids. So, this one, it's a little bit blurred. But then I realized that was my kids a few years ago. My kids are a lot louder today. Quite not as cute. So, all right. Does anyone know what number 52 is? Very important for anyone implementing Epic. It is the number of calls I get every week from consulting groups. I apologize if I don't answer my phone enough, but Epic definitely keeps us busy. So, as we get started, a little bit about the history of Boston Medical Center. So a little bit about the history of Boston Medical Center. We are the largest provider of Medicaid and Medicare services in the Northeast. We have the highest volume emergency department, and we have the largest level 1 trauma facility in Boston. We have a significant ambulatory volume, and we have an inpatient volume, I'd say modest compared to many in the city. We're affiliated with 15 community health centers, many of which we support their EHRs. And we've been doing this for a long time. We started implementing electronic systems back in 2000, before I was there. We started with the inpatient, we moved to ambulatory. We've been rolling out since, and today we're predominantly electronic, and we have very little left on paper. Very proud of that, but it has also caused us some pain points, of which I'll talk about in a few minutes. In addition, to keep these systems moving, we have utilized the best-of-breed strategy. So no different from many academic facilities from years ago, and it has caused us problems, as I said. We deployed an interface engine, and we need almost 400 threads to keep the information going. It's a significant effort every week to keep this information going, and in the end, it's still not meeting the clinician's needs, as we'll talk about. We have a significant and a very robust data warehouse. We extract data from all of these systems. We utilize the data for quality, for reporting, but again, it doesn't help the clinicians drive their day-to-day work in front of the patient. So it still leaves a lot to be desired there. And then I'll say, and finally, when I first joined Boston Medical Center, we were the team everyone loved. They all wanted to work with us. And over the past several years, so many years, that I've been there, we have slowly transformed into the team that everyone wants to wring our necks. So it really has put us in the position of we are helping them, we're enabling them, but at the same time, we're really hurting them with our systems that we have today. And we really acknowledge that we've gotten to a point that we can do not much more with them, and we had to look at a new strategy. So the best of breed that we have, if we look at them, is really a fragmented patchwork of electronic systems to help meet the clinicians. But as they work with the patients for the continuum of care, they are having breakpoints along the way, and they're really struggling to actually see all that information together. The seamless integration that I talk about here, one of the challenges for them is as they have different points, and the next few slides I'll show you, the patient flow, the information that goes with them is all readily available to them. But because they have such little time with the patient, the information is not readily at their fingertips, and so the seamlessness of that patient care is really inhibited. And we'll show that pretty significantly in a second. We're showing that we have significant negative delays, as I talked about the amount of time that they have. And so as the clinicians have increased RVUs and increased demands to meet their expectations, it has increased the frustration they've had on our electronic systems. And I do want to say that our current systems, because we have so many, we also have some significant concerns about the vendors in the marketplace. And as we've seen over the years, several of the vendors are merging, partnering. I've experienced that through Allscripts and Eclipses, and the longevity and their viability in the market space has been called into question, and so that also led us down this road. And so because of that, it has really created gaps in quality and safety. So for us, in particular, with all of the best-of-breed strategy that we have, it has caused problems with areas that you would think to be so simple. And so when you talk to clinicians, and I'll show the examples on the next slide, when you talk to the clinicians about things that they just say should be straightforward, I'll show you about allergies, I'll show you about problems, things that they need to care for the patient are not at their fingertips. And so it causes a lot of duplication, it causes a lot of waste, and it causes errors. And we've seen errors along the way that has led to financial challenges as well. So here's a few examples. The first one is a chemotherapy patient. So our chemotherapy environment has a our outpatient environment has a complex documentation strategy. So they needed the ambulatory system that has a much more robust documentation system. But they needed the order entry of the inpatient system that connected to our pharmacy there. So they work in two major systems. And so for something as simple as taking a patient's weight, it has caused many errors along the way. So they have to enter the weight in the inpatient order entry system for weight-based dosing, of course, for chemotherapy patients. And they have to enter that weight in the ambulatory system. And so for them, they have to manually reconcile every time they're going to treat a patient to make sure that they're actually, the weight-based dosing is correct. So a manual process that is flawed with and has seen many errors. We created this temporary workaround. You can see on the lower right. It's a view only. We created a look into our ambulatory system, pulled in that data, and we presented to the clinicians. But it's still a manual that they have to manually reconcile it and then enter that data in. It's not ideal, and it has certainly led to errors. Immunizations. A baby is seen in the inpatient area, gets immunized, whether they're born at BMC or whether they come in for an inpatient stay, and then we see over and over again over-immunizations that happen in the ambulatory environment. The reconciliation that has to happen is manual, and therefore the clinicians have to look into these different systems. They get 15 minutes to see this patient, it doesn't happen. Repeatedly, patients get over-immunized. And this is not just pediatrics. Over and over, flu, pneumovax, immunizations is a major area of weakness that we have with our systems. And then, of course, wouldn't it be great to have one allergy list? So what an error-prone system when you have 3 main EMRs in front of you with the inpatient, ambulatory, and ED, and none of the allergies. Something that the clinicians all look at me and say, how is this difficult? Why is it so challenging to have one allergy list? Well, we don't have one formulary. There's no one standard. There's no vocabulary manager that normalizes allergies. So to do that today seems so simple and is highly complex. And so we've struggled for this for years. So our temporary solutions, we created a view-only system that pulls in data from all 3 and presents it to the clinicians. It gives them meds, problems, and allergies. It allows them to view that, but it's a manual process. It takes time from those clinicians. They don't have that time, and we see errors because of it. So a few examples of why we did that. At the same time, Boston Medical Center started going down the path of creating a new strategic plan. And at the heart of this, well, I shouldn't say the heart of the strategic plan. One of the major items of the strategic plan was this challenge for the clinicians. And so the need for an integrated EHR or an integrated solution to treat those patients and help the clinicians throughout the continuum of care was to pull the integrated system in and help with many aspects of the strategic plan. And most notably, we had several, but I highlighted the right care, lowest cost and lowest provider, and our lead in integrated care. These are 3 of our goals through our new strategic plan, and an integrated solution helps greatly with this area. So, what did we do? We got asked to start to evaluate our systems. We got asked to take a look at what solutions were out there in the marketplace. And we got asked to find what worked best for Boston Medical Center. Not specifically, not what was the cheapest, but what would be the best solution long-term to meet our strategic plan. We started off with 4 vendors. We brought in a consultant group that had helped us, or that to help us, that had done assessments in academic medical facilities. And we started with the notion of why Boston Medical Center is so different from other organizations. We knew that Yale had already purchased Epic, we knew that many other academic medical facilities had, and we knew in the local marketplace that others were going down that road too. And we said, why is Boston Medical so different? In the past, we always looked at ourselves as so unique. Everybody thinks they're unique. The clinicians always want everything unique to them, and that has set us up with our systems. So today, as you've seen some of those systems, we've over-customized them. We've gone down the road of making them all unique to Boston Medical Center, to the point that we struggle to support them. In the end, we decided, why is Boston Medical Center so unique? And let's start with that premise as we go down this assessment. So we went down and we looked at 4 vendors, and we took one off the table, and we brought in the other 3. And the other 3 were looked at, and we started off going down in this big RFP process, and we were going to go down similar paths that we've done in the past. And again, we said, we have to do this differently. So we said, why is Boston Medical Center so different? So what we did was we said, what is unique about Boston Medical Center? And there wasn't a whole lot compared to other academic medical facilities. We do a lot similar to other academics. We might do it differently, but we do a lot of the same services that other academics do. So we started off by interviewing the vendors, and then we brought in the 3 vendors, and I wrote a script for all the vendors to follow. We brought them all in, and we asked them to do a demonstration. We asked them to show the continuum of care, the main point that we struggle with the most. We asked them to start with a patient that's seen in the ambulatory environment. We wrote a script to go to the emergency department, get admitted, go to surgery, go to the ICU, go to the inpatient, get discharged, get follow-up care with your PCP. We wanted to see how that would work out for the patients. And in the end, we did that. And that was actually a very successful way of forcing the vendors and forcing them all to show apples to apples how and what would work best for Boston Medical Center. So the evaluation process happened, and over several points, we overwhelmingly selected Epic. We looked at all 3, and again, it was not about cost. Certainly the inpatient environment, we already had the system in place, but we had significant concerns about the vendor and their ability to integrate the solution in the time frame that we needed. Their presentation to us talked a lot about in the future, and in the amount of time after we are implemented, how long after would we have a complete integrated system. And our feeling was, if we're going to do this, we can't put the physicians through more pain. And if we go live with this, and it's still not a gross improvement from what we have today, I felt that we would be doing injustice to our clinicians, and that was, in fact, what others felt as well. Personally, I felt that I would be the first neck that they would all grab, so we didn't want to go down that road. Others were surprising in terms of cost, and surprising in terms of functionality, and overwhelmingly the clinicians. And this was a clinician-led effort and a clinician-led decision. They selected Epic, so it was their decision. So we went back and we said, okay, we went into this to say we hear Epic is not cheap. So do we have the ability to do this? Boston Medical Center serves Medicaid, Medicare predominantly, so our budgets are always tight. So it is an oxymoron to say you're doing a cheap Epic implementation. I will not insult anyone to say that. But for Boston Medical Center, we often do things on a lean scale. So our strategic planning office created justification for this, and they went to the board, and we went to the finance directors, and we said, total cost of ownership over 10 years is actually cheaper with Epic than some other systems, and it's going to help us in these areas. And we looked at areas of quality, which has been the drivers, clinician-led initiatives, and that clinician was actually our chief quality officer and our chief technology officer, all about quality and safety. How could we help us there? How could it help with operational improvements? The amount of clinicians that were screaming about our current systems, about how error-prone they were, and how much extra work they caused them, how much of a delay it caused them in terms of treating patients and their care. And then in terms of what's happening in the industry, in the ACO preparedness, how do we align ourselves? We talked about that we have 15 community health centers, and how do we set the framework for an ACO with them, and then a future expansion if that was to happen. So the first thing we did was we created a core planning team. Specifically did not call it a steering committee. And we did not because we knew we had to do it differently. General theme of my presentation, we had to do this differently. The core planning team was charged with getting us going. We were charged with setting a timeline. We were charged with establishing an Epic contract. We were charged with establishing a team, finding real estate for ourselves, and establishing a scope. Now I'll talk about those. But this group was a limited time frame, and it was not a steering committee. And it was not a steering committee because we had to limit the participants. We had to limit the outsiders who all felt that they should have a voice again. In the past, everyone felt like they should get it their way. And we needed to really be streamlined with those who were on board with how we were going to accomplish this goal. So we started off with this core, and we met on a weekly basis. And we established those goals. And we met for a few months, and we were a very successful group. So we set the timeline. When we looked at this, we said, what do we have to accomplish, and what time frame do we need to get there? So predominantly and overwhelmingly, one of the chief factors was ICD-10 and Meaningful Use Stage 2. We were an early adopter of Meaningful Use Stage 1, actually self-certified our inpatient environment. Proud we were the 7th hospital in the country to do it, under CCHIT. But the timeline was such that we knew we couldn't do that again for Stage 2. And for ICD-10, the amount of work, the amount of effort, and the amount of cost to upgrade our current systems to remediate those EHRs in addition to all the other systems, again, it's a best-of-breed strategy, we have to upgrade about 20 to 30 different systems to meet ICD-10 remediation. We knew we were going to struggle to do that. So we set a timeline to say we've got to get this done for ICD-10. So our hospital environment is about 12 months to the day, almost, so May 24th. My fantastic project manager is sweating over there right now. So we've got 12 months to get this done on the inpatient side. And then on the ambulatory side, we have to May of 2015. And initially we went down the path with Epic of saying, they encouraged us to say we could do a big bang. Their strategy is often big bang, you can get it all done together. We had a New Boston Medical Center, and we knew we had to do things differently, and we knew we would have some challenges. We know we'd have to push back about the amount of customization that we would not allow, not that we would. We knew we would have to push back about all the involvement and the amount of uniqueness that we would have, and the amount of specialties and the amount of doctors that we had. Epic had major concerns about with the time frame that they had initially presented. So as we got into it with them, we realized that we were going to have to do some remediation for ICD-10 on the ambulatory environment, and we're doing that today. So we have a split go live. We've got inpatient 12 months from this month. We've got ICD-10 in October. We hit the holidays, and then we hit ambulatory. So won't be sleeping much till the end of 2015. So again, it was all about those key milestones. And then there's some other drivers. Those clinicians were tamed for a short while as we selected Epic and as they knew we were going down this path. But I would say a short while. That frustration has grown back loud and clear. And they will only tolerate it for so much longer, and they are really struggling. And as they get pushed to have higher demands, as they get pushed to see more patients in shorter periods of time, those screams about our current systems, knowing that we're moving to Epic in 12 months, are getting louder again. And so the current inefficiencies are becoming more intolerable. And you can't blame them, and I can't blame them, and I never disagree with them. But at the same time, there's only so much we can do on our current systems. And so we've got a clear path, and we've got a very aggressive timeline to get there. Support for existing systems, we figure will start to wane. And industry trends towards ACOs, population health, those are all going to increase. And the more those happen and more regulations that come, when we're not on Epic, the more we have to do in our current systems that is both throwaway work and pain points for kludgy workarounds, quite frankly. And then we knew we had others locals in the marketplace. So I know some are here today, and we felt we needed to get out of the gate fast. We had heard rumors of others down the street that were going to go to us. We knew of other major systems that had already selected. We knew Rhode Island was coming, and quite frankly, we knew several others were starting to look at them. So both in terms of retaining our own staff, recruiting new staff, and bringing on successful consultants, we felt like we had to get out of the gate quickly to get this done. So we look at our current systems when we define scope, and we looked at our clinical systems. And this is our major systems that are getting replaced, not our full system set. And we looked at, this is our clinician's environment. She's smiling. I promise you she doesn't smile when she deals with these systems. So then we lay Epic in, and it starts to simplify our environment. It really starts to consolidate our portfolio. So the approach that we chose here was that it would help not only the clinicians, but quite frankly, IT was struggling as well. We had developed all these systems, we had over-customized them, we had too many environments, and in this day and age, we had shrinking staff. And the ability to continue to support this environment and the ability to continue to meet the clinicians' high expectations is becoming more and more challenging. And so as that happens, IT is second in line behind the clinicians excited about moving to Epic. So we looked at our scope, and as I said, this is about core clinicals for us. And the core clinicals for us was replacing our main EMRs. That doesn't mean that others did not want on board, but again, we had to do it differently, and we had to stop allowing everyone else to take over our projects, which is often the case in many large projects, and often the case of Boston Medical Center. So specifically, what we left out of scope. Many people wanted these in scope. We were looking at revenue cycle. We purchased the enterprise solution, so they knew we could implement these systems. But in the end, we had to do it differently, and we had to set our scope. And so that core planning team set the framework to say, this is all about core clinicals. If we want to get this done, we want to get this done in the time frame we have. We got to be realistic about our goals. We got to be realistic about our expectations, and we got to set reasonable goals because we've got immovable dates. The government has set regulatory dates. These are not in the past that we've had a timeline that you can continuously push off dates. We have a backup, so to speak, but it is pretty awful backups if we met these timelines. So essentially, it's May 2014 or bust. So we do this, and we pushed off the ancillaries, and we pushed off the revenue cycle, and we pushed off our community health centers, much of which we're not happy, but we knew we had to set the framework to actually be successful. So that's how we did that. We also set a strategic goal of doing like for like as much as possible. I start off by saying we're highly electronic. We don't have much left on paper. ICU nursing flow sheets is pretty much on the inpatient side, by and large, the only thing left on paper. So that got thrown in. And what we did was we said, if you're going to add something beyond what we do today, what we're going to do is we're going to have to justify it under 3 categories. And that was, again, about safety and quality. We looked at finance and revenue, and we looked at efficiency of the clinicians. All the 3 themes of what everyone's pains were. And you have to justify it that way. And everything the clinicians will say is valid, and everything they will say is a patient safety issue. So we really had to scrutinize that. And so we had a clinician-led effort led by our chief quality officer. I have a chief medical information officer, and they really helped vet that to say, yeah, we hear your concerns, that's a real valid issue, but that is not to the level of a safety concern that is going to drive us to the point that we're going to be concerned about our timeline. And we really pushed back about a lot of that. So we added some areas in, and we set our scope, and we're really trying to stick to our scope, and we're really trying not to adjust that. We've had many pushes from different areas. We've had many areas where people could really benefit from it. It's really painful to tell them no. It was very important to have the support of our VPs and my chief quality officer to have the support of saying, yes, I know you're experiencing this pain. No, you cannot be added into the Epic project, and that was essential. We started building up a team. We were tasked with a few of us were tasked to build up a large team in a short period of time. So Tom Nagel and I sat in many rooms where I did not answer many of your calls for many months, where we just interviewed people, and we brought on a lot of team. And strategically, I put my money on leadership with Epic talent, and we did that. And then we put in a lot of analysts who had experience or not a lot in other areas. And we did that, and I say not a lot because we actually set, one of my goals was to actually set an org structure to address some of my prior challenges. And one of my challenges was I'd have clinicians, I'd have analysts with me for several years, and then they'd get to a point where their career was stalled and they felt they needed to do more, and I didn't have any opportunities for them. So we set a framework to reduce the flat structure and make a lot more opportunities. So we created new levels of positions. I had to write several job descriptions that was beyond fun to do. And we set those, we set the opportunities, and we set internal opportunities, and we tried to promote from within wherever possible. And we set the opportunities for the long-term growth where there's stepping stone positions now, where in the past it was very flat, and we really encourage people to move on if they want to enhance their careers. So that was one of the things I set out to do. In addition, we also